The Senior Rehab Podcast is sponsored by Health IQ. Health IQ is a special rate life insurance company for health-conscious people like you and me. If you're in the market for life insurance to have peace of mind and to protect your family, I'd highly recommend checking out this company. They are the only life insurance company to use data to leverage lower life insurance rates for active individuals. So the result is that 56% of Health IQ customers save between 4 to 33% on their life insurance premiums, which can definitely add up to big savings over time. To find out more information, just go to healthiq.com/SRP to support the show and to get your free quote. Hit me!
This is a Senior Rehab Podcast, the podcast for rehab clinicians that want to better serve older adults.
Hello and welcome to Home Health Recharge. This is Troy Mead and this is our kickoff episode. We're starting off with part one of a discussion with Celeste Cheek. Celeste is a PT with a lot of experience in home health. She started in home health right out of school, left, came back, and now is currently working in the setting. We talk about how home health has changed, reassessment visits, changes in conditions of participation, technology, paperwork, changes in OASIS, and others. Without further ado, here is part one of our conversation. Hello, welcome to Home Health Recharge. This is Troy Mead. I'm your host, and I'm here with Celeste Cheek. And today we're having a dialogue about the changes that home health has made throughout the years. I've been in home health for close to 8 years, but Celeste, how long have you been in home health?
I started right out of school in 2001. I've taken a couple of breaks. I did acute care for 2 years, I think, in a heart hospital and a couple of years at a skilled nursing.
Okay, so you've kind of seen how a patient can progress all the way through, you know?
I have. It changes my view every time I switch fields and come back, but I always come back.
Yeah, I think that's a good perspective to have. You know, I spent a little bit of time in acute, but not as much as I could have. It's mostly been an internship and a quick stint before I went into home health. But, you know, like you said, it's funny when I just came out of, I spent about 6 months in acute. It was a long-term acute facility. And I saw about 5 patients that I saw in the hospital when you're at home. And like, oh, hey, you're here now. I was like, yeah, hey, yeah, good to see you.
Yeah, I still know you. Yeah, and I worked for skilled nursing here in Yakima, and I still occasionally do some PRN, and I come across some of those patients that I knew in skilled nursing or that I still see every now and then. They ask me to do an eval, and then I end up seeing them in their home too. So it's helpful to see both sides.
Yeah, it is. It helps with that rapport too.
Mm-hmm.
So we came together because we wanted to talk a little bit about how home health has changed, over the years. And right. Just the short time that I've been into it, I've seen a lot of change. I know when I first started the company that I worked for, and, we really didn't do a lot of vital signs in the home at that point. And, it was right before we had that, the infamous 13th visit rule, 14th visit. I think everybody who was around at that time knows exactly what you're talking about.
I think that would be what scared me to the hospital for a couple of years. But
luckily, it only lasted about a year. And for those who weren't in home health at that time or on the outside looking in, Medicare had a rule. It was about, 2015 maybe?
No, that was before then. That would have been... Oh, geez, I don't know. I was working in Cleveland, Oklahoma. I just know that in the rural areas, the 13th and the 19th, you had to go back between 11 through 13 and 17 through 19. You had to go and do a reassessment, one of all the disciplines. So,
right, and the big thing that was with that was it was the 13th visit between all the therapy disciplines that we're in. So,
right, which was a huge issue if you had a speech therapist that only came to work with you once every 2 weeks from 100 miles away. That is what we ran into then.
And you had to coordinate it. So, if you did your reassessment and the speech or OT wasn't going to come in until about a couple more visits, you really had to wait until they came back and did their reassessment to go back out. So it made it tough to schedule around that.
Yep, that was rough. that was probably Medicare's dumbest rule to this point, I think. But I'm glad they got rid of it.
Yeah, I have to agree with you. But you have to at least give them credit that they did listen to us and they did go back. Yes. They walked that one back a little bit. So
yes,
so that's good.
Yeah.
But how have you seen, let's go with regulatorily, how, with the regs and everything, how have you seen that change since you started until today?
Well, when I started, back in the Stone Age, internet was still fairly new and dial up, and it was pretty much go and do what you need to do. There was no limitation that I knew of, but I didn't have any access. I didn't know where to find the access. I was a single mom at that point. I wasn't an APTA member. I don't know that the home health section was around yet. I don't know when they started. But I had a fellow PT that I'd gone to school with that we talked a lot on the phone and spent a lot of time on AOL trying to find the rules, because we both ended up working for a company that would not let us go out more than 10 visits, which it was kind of like the 13th thing, only when you get, there's some companies that chase the money, which put us in the situation we're at now. And when you end up working for them and they say you can only do 10 visits, that's all you get. You know that that's not right. There's no way that you can possibly say that, because it's no way. You can't be right, but there was no way to find any of that out then, except for, I don't know, go to Congress and get a book or something. So it was rough. I mean, I spent days on the computer, which I could probably do in 20 minutes now, because cable's a little bit quicker. But so there was that change with the companies that limited you based on the finances of what they were going to get paid, which I understand. You've got to be financially responsible, but if somebody's really ill and really needs therapy, you can't say no, you have to stop at 10. And if everybody stops at 10, it's just wrong, I tell you.
Yeah, it makes it hard to have that patient-centered care,
It does, yes.
When you're only able to see a patient for so many times, I think,
right.
Outside of, there always sometimes there's those insurance limits,
right.
I think you see that more in outpatient than you see
right.
in home health, where they just cut you off and stuff like that. But
and I guess my thought was, they're coming straight home from the hospital and you want us to take care of them and keep them out of the hospital, but you're only going to let me go this many times. And it was really difficult. Even if you could justify why they needed it, it was so hard to get more visits, at least from this one particular place. I ended up leaving because I didn't like that. I went and worked somewhere else that let me go and see patients as I needed seen. So, and I found out more. That's when I started getting more into the regs. I guess I've been digging into regs since then, because I want to do what's right for the patient. And if you're going to tell me I can't do something, I want the law or the rule, prove it to me why I can't go.
Yeah, I think that's smart too. I think that's one thing. I think new clinicians and some other clinicians just don't really dig into that as much, and they just kind of do what they're told to do sometimes, when they really,
right.
It really does you more benefit to make sure, because it's your at the end of the day, it's your license.
It's your license, right? Right, and it's that person you're caring for. I mean, you don't want to cut them short if they need to be taken care of, and it's their insurance, it's their health, it's their well-being. That's what you were there for. It's your job to try and help them along their way. So we do what we can.
Yeah, and I know, you were talking about the visit limitations. For the most part in this area, we don't have a lot of issue with that. But Medicaid is not
Medicaid, yeah,
not great in North Carolina. So hopefully that'll be changed.
That's different by state, right? Because in Oklahoma, we weren't allowed to see them at all, and here we do, and they actually do. I don't know. It depends on the plan they have. They get more and more confusing, but I can usually justify and get what I need from the companies here. So
it's usually by state. North Carolina is more kind of like Oklahoma. They get unless they have a total joint, or if they get a total joint, I think they're allowed 8 visits max. And then if they have a stroke, I think they get 12. And otherwise they get, I think, 2 visits. So,
2. Yeah, that sounds pretty standard.
Yeah,
we can do a lot and do.
It's kind of funny. I also volunteer. There's a great little pro bono clinic that's associated with the local university here, and they do a lot of good work. But around this time, they lose all their patients at the turn of the years because their insurance goes over. Most of them are Medicaid. They have to go, and some of them have no insurance, but most of them have Medicaid, and they have to go get their one PT visit and come back. Right. It's funny, but it's true. So.
But that's awesome that you do that. That's hard to do, doing home health, and home health tends to suck me in for many hours a day.
Yeah, I do it for good reasons and selfish reasons, just so I can keep up to date on
right.
All the students do all the work. I just supervise. So.
Oh, nice.
And they're a great bunch. So it's some days it's easy, but when you get that complex patient, they need a little bit of guidance. But it's fun. I really enjoyed working with. That's one thing that I really enjoyed in the other settings was working with students, because I was a CI and I went through the APTA credentialing and everything like that. And then not that my company does take students, it's just they don't come around very often, so I never have the chance in the
I think Yakima has a PTA program, because I know the PTA that pulled me over here went to school somewhere around here. She was actually a student where I worked, and then went to work for them.
That's cool.
So we must take students. I haven't seen one, but I should go and get my CI license. That would be fun.
You can do it without the license. It just helps you with guidance and everything like that.
Right.
It was a personal decision to go through the class at that point. I had taken a few students beforehand, and it's definitely not a prereq. But it's just a fun little thing to take, the paperwork now, a lot of it revolves around the paperwork. I can't remember what it's called, but I'm sure someone will remind me of it. But but now it's all electronic. Back when I was doing it, it was paper. So now it's even
way back in the day.
Yeah, way back in the day.
So my first job out of school was doing home health in a town called Coyle, kind of between Coyle and Langston, which had, I don't know, maybe 100 people, and it was near the college where I went. And I couldn't find a job anywhere, so one of my instructors called one of his old students who was running this hospital / home health / outpatient. So she put me doing home health, and there was no GPS, and nobody knew where they lived. And you could spend hours in the middle of nowhere with, I didn't have a cell phone then, because I didn't have a cell phone until I moved to Oklahoma. So there was, you had to, stop and use a payphone to try and find someone that doesn't know where they live. And at least if you're at a payphone, you know where you are.
Right.
Later on, when I went to rural Oregon using the Google printed maps or Rand McNally printed maps with a cell phone. I didn't know where I was. They didn't know where they were. As soon as the GPS came out, I was like, I got to have this. I have got to have one of these.
We are the younger clinicians, and like I am, that never worked without a GPS are definitely spoiled. I grew up at a time where before I worked, in college and stuff, they didn't have GPSs, but back now, we have GPSs, we have cell phones. It's really hard to get lost. I mean, you work in a rural area, of course. I have gotten off the road and had to call a patient. They're like, "Well, you drive through the cornfield and you take a
yes. Where Jimmy Bob used to live."
Yeah, technically their address is right off the highway, but really.
Right.
And now a quick break to tell you about our sponsor. This episode of the Senior Rehab Podcast is sponsored by Health IQ. I mentioned before that Health IQ is a special rate life insurance company for health-conscious people like you and me. They have a unique mortality model on health-conscious people that allows them to secure lower rates based on actual data. You can think of it like good driver savings on auto insurance. They also have a unique underwriting process where instead of using common measurements like BMI, they use waist-to-hip ratios, cholesterol calculations, and much more to demonstrate a more accurate view of someone's health. So if you're in the market for life insurance to protect your family and have a little bit of peace of mind, I highly encourage you to go to healthiq.com/SRP to get your free quote and help support the show. Thanks.
It always got me that people said pass the first red light, and I am so literal. Like, what if the light isn't red? Do I keep going until I get to a red light? Is there one that's always red? That was an Oklahoma thing, though. It's the only time I read that.
Oh, that's funny.
Yeah, when I was in the city, in Phoenix or Tucson, they had map books, and there was a grid of, I don't know, maybe a square mile, but you had to go by the, C4 from the main grid and turn to that page. And then if you happen to need to turn to the next page, it was like 5 pages. It's such a convoluted mess, but I mean, it was kind of a puzzle to put together. But I noticed when I used a map, and then you just, you learn where to go, especially if you move around a lot like I did. It's a fast way to learn a city. Mm-hmm. But I was here for a couple of years and didn't do home health. I was here too before I started home health, and I used my GPS to get to and from work and to and from the grocery store. And you get in the habit of looking at that thing to see kind of where you are, and you miss where you are. When I don't know, it broke or something. No, it got stolen out of my car. So I went for a week without a GPS, and it threw me. That just going to the grocery store really kind of freaked me out, that I didn't have my blue line in front of me, and I know where I'm going. It's down the road, but it's really easy to become dependent on those and miss your surroundings. So I try and go without it now sometimes, just because now I've learned the city, and I use it to get to my patient's house the first time, but I try and find my ways around. There's lots of shortcuts you can find if you don't use the GPS. Yeah.
I'm kind of paranoid the same way too. If I don't, even though I know exactly where to go, it's like I still got to put it in there.
Oh yeah. You know what I just did recently? This was maybe, 3 weeks ago. And this is really stupid. I put an address in the GPS, and it was on State Highway 420, which is straight down the pass. And it is, I know the highway, it goes by my house, and I put it in the GPS because it's a highway, it's a rural address, and I want to kind of know, is it 10 miles away? Do I need to start looking for mailboxes now? Because I'm in the mountains and I'm in nowhere land, and I don't have reception. And at this point, so the GPS tells me to turn off of the road to go. I'm thinking it's going to take me. Maybe it's going to take me on one of those little back roads. It's going to drop me right back down at their house from a different way. Maybe this highway splits. I'm not from here, so maybe there's something I don't know. So I follow this stupid GPS directions for, oh God, 30 miles. It took me into the brown sign roads where you're in the forest and you should be camping, but they've closed all the campgrounds, and now you should be four-wheeling.
Right.
And the road well, that's where I ended up. And it's like, you have 2 miles to go. This is a new car and I have four-wheel drive, but I really don't want to test it out here with it. So I have no reception. My GPS will not tell me any other alternate route. So I pull out my phone and it's roaming, and like, okay, surely you're going to give me a different way. And the only way to this guy's house was 30 miles back around. It took me 70 miles to get to this house that was 32 miles from the office. And I get there and I still can't find it. Mile marker 314 or something, and there's nothing there at the mile marker. Like, okay, I passed one like lodge with a sign on it. I'm gonna go back there. I'm gonna pee and find out where I am. And the guy's like, "Are you looking for?" Yes. She said, "She's right here." Like, okay. Oh, luckily she was wonderful, and but yeah. So I don't always trust the GPS. I still want a map in my car.
Yeah, it has steered me wrong a handful of times, I would say too.
I thought I'd take a joyride.
Have you seen any changes? Like, I'm assuming you've seen some changes from the paperwork, the EMRs, and everything like that. You've probably went from paper. I mean, I'm going to totally put words in your mouth, but went from paper to more electronic.
Yes. I'm trying to think how it was when I first started. I don't remember writing notes when I first started. Well, I mean, I wrote, like a soap note for that first country job. And then when I started taking my first full-time job was an outpatient clinic in Tucson, and it got slow. So I took a per visit job, and I just remember the Oasis on paper and being handed this giant stack of paper, and I mean it covers everything, and I'm new student. I mean, not new student. I felt like a student. I didn't know what I was doing. You want me to ask him about their kidneys? There's 30 pages.
Yeah, there's a lot of questions that if you're a new therapist into coming into home health that you might not be real comfortable with asking. It's not the typical questions that we ask. And
no. And now it's become, I mean, it's second nature to ask, even if I'm just doing an eval, because I try and do an overall assessment, because it's such a holistic thing that we do. We need to know. But, question by question, like, do you, even for the admit, the consent to treat, do you have renal failure? Have you had black lung disease? All of those, word for word, and 3 hours per person, and that was a little spooky.
Would you say that
go ahead.
that the electronic EMR has made the Oasis any easier, or would you say it's made it more difficult?
It depends on the size of the device that you're using. Probably easier. I guess it depends on the system. I know on one system I used, it was very helpful when you went to do your discharge or a transfer or a Zoom. It would kind of show you what you had before. Mm-hmm. But the system I have now, you can find that out. You can go and look it up without having to pull out a giant paper chart. Mm-hmm. So yeah, in some ways.
Yeah, I know what you're talking about.
It really depends on the system.
Yeah, the one that we use tells you if you've had a previous Oasis, if the patient's made progress or not. So that is nice. So
yeah, we've got a human who goes through them, and she likes to give me little notes that says it didn't get better. Like, no, but it didn't get worse.
Right.
So, yeah.
I think we as therapists, and we get so so uptight if everything doesn't get better, but that's not always
always the
the
case,
best.
right?
Yeah, it's not always the case. It's not always the best thing. Some things aren't going to get better, but it's what the meaningful increases that you've made it, and you target. The ambulation you might get better, but this might not get better. So
Right.
it is what it is. But you're right. You don't want it to get worse. That's what's scary.
Those are the ones, yeah. And and I have those that those are frustrating and hard to swallow. But if they decline, and hopefully you can keep them from declining further. But
Right. Yeah.
don't like it when that happens.
Yeah. I don't think anybody does, but yeah, you're totally right. Sometimes it happens. Sometimes it's perfectly appropriate, and it's just a consequence of their dyspnea might get a little worse if they're up and walking a little bit more or something like that. Sometimes it's just one pushes on the other, and it's just a give or take.
And I used to struggle with that. I was talking to another therapist about this the other day. Somebody that doesn't have arthritic pain in their knees anymore because they sit and don't move. But they want to walk, so you get them walking, and they're starting to walk, and they're getting more pain because they're walking a little more, and eventually that will get better. But on the Oasis, it was kind of they're always in pain now. So my go-to is always I keep a copy of the Oasis, the guide. Is that what it's called? The guide? I don't know. I keep the thing where you go and look it up to find out what exactly what they want.
Like the Oasis answers. I think that's a brand, but with the answers that with clarification on the questions and stuff like that.
Yeah, it's the CMS. I mean the Oasis thing. I just lost my words totally. Chapter 3. I don't know. It's Oasis Chapter 3 right on my computer.
Chapter 3 Q&As. Is that what?
No. Where it goes to the Oasis and it tells you each question. This is the guidance manual.
Yeah, there you go.
That was right. That's the guidance manual. I keep it on my computer. I learned once at one traveling place I was at, I had to take an Oasis, like a certification type of course, and she talked a lot about looking at the ifs, ands, or buts when they say that in the Oasis. They mean and, or they mean or, and you really have to look at those, and look at everything in the sentence. Don't just take the first 5 words.
Yeah, I went through the course and the certification.
That's right.
And I recommend anyone who's in home health, if you think you know the Oasis, take that class, and you'll feel like you don't know anything. Because
I want to take that class.
Yeah, because you're right. You got to look at the ands, you got to look at the ors. You have to, if they don't fit in this one. Sometimes I think that's the hardest thing. You're trying to fit the patient into a box, and into 4 or 5 questions, and then they might not fit perfectly. So you kind of have to go, top down most of the time. And
that's something I've learned more through the years. I went straight. I mean, I had no training in the Oasis. It was a nurse that handed me the thing and said, go see someone. So I did, and just asked every single question and struggled with the questions that they didn't fit into, because you have to fit into a box. What do you mean? You have to do one or the other. There's no if here.
Yeah, I think too, as therapists, when I took the certification, I was one of, I don't think there was another therapist in the room. There might have been one more in the room. It's a room full of nurses, and it tends to be what they said is, the therapists tend to struggle a little bit more with the functional questions, because they're written for a nurse or a therapist, or anyone to answer the question. But we don't all speak the same language as a nurse. So it's kind of, if I had to say, this isn't legitimate, but what I would say is that it's written more towards what a nurse would consider what minimal assist or something like that, not necessarily what you learned in PT school or OT school or whatever. So sometimes we kind of struggle with that.
Crosswalk somewhere that shows. I don't remember where I found it. Maybe on the home health section, a crosswalk that shows when therapists read Min Assist, they think this is really what the Oasis means. Mm-hmm. That kind of takes you through those, which has been helpful.
Yeah, I think that's where we struggle the most. I see as therapists. Yeah.
Well, there was quite a few years that I didn't have to do it. I worked for companies that the nurses did it, and at first I was like, yes, thank you. You go for it. But, I felt kind of left out, especially when a nurse was just going to do it non-bill so that I could go and do a total knee. Like, I can do this. I really can. There's no need when they're scrambling all over the county trying to get, daily dressings done or 3 times a day INRs. Let me go and do the Oasis. But this place they do. So that's nice. And that may change for people. I don't know if that's going to change with the COPs or not, but
it hasn't changed the last time that I checked. I didn't see anything like that change in the newest ones, but yeah, that's legitimate as long as they don't, if it's a PT only, they can send out a nurse to do the Oasis as long as they don't bill for it. They can't bill.
Right.
So, that's still legitimate that I know of. So
yeah,
I don't, a lot of places I don't think do it because it's not real cost effective.
Yeah.
But there's still some places that do it.
Mm-hmm. There's quite a few.
Yeah.
So I didn't have to do it for a while.
And so I've never worked for a place that's done it like that. Did they only do the starter cares and the rocks or something, or did they do all Oasis? Well,
they did all of it.
Really?
Yeah. I'm trying to remember. I don't think I ever did discharge Oasis at the last place I was at either. Because I missed the Oasis C came when I was doing home health, and I had to totally relearn it because it was different. Because I hadn't dealt with it at all.
That's the nice thing about the Oasis. It changes.
It does. It's changing again next year, right?
Is it?
Mm-hmm. I think they're taking out a lot of the... they're taking out quite a bit, I think, on...
I guess I got to look into that because I know that just changed again with C2.
Yeah, in 2018, and this is 2018. Hello. 19 or 20, they're changing something. I don't remember. I get lost in the internet now.
I'll take your word for it. I mean, the one thing you're definitely right on is they're going to change it again sometime anyway. So better now than never, right?
Keep learning it. Yep.
So there you have it. I'd like to thank Celeste for sharing her perspective. Please, if you have any suggestions, then please reach out to us on Facebook and Twitter at Senior Rehab Project. And check out part 2 next time. Until then, don't forget to stay funky.
Hit me! Thank you for listening to the Senior Rehab Podcast. If you only listen to these podcast episodes, you are missing out on 90% of the Senior Rehab Project. Hop on over to seniorrehabproject.com where you can join the movement that's advancing care for older adults. You can join for free or become a part of the Game Changers where you can get some free gear and access to our monthly meetup. Just go to seniorrehabproject.com. I appreciate y'all, and I'll talk with you soon. But in the meantime, do not forget to stay funky.